Welcome to the first in-person CCD meeting in quite some time. Thanks to everyone who's here in person and also to people who are online. First SWOG virtual or hybrid CCDR meeting. Well, hopefully there won't be any hiccups, but if there are, we will take a pause so we can make sure everybody on both ends of the meeting can participate. So we'll just get right to our first presentation.
I think we might have a few slides.
Or do we? That's no, I'm not hooked up. Can you advance over there? See, already. There we go. It's not advancing. Stand by while we deal with our technical difficulties.
So just as a couple of announcements, if people do have questions throughout, please come up to the microphones. People online cannot hear if you just speak from the table. So afterwards, please come up to the microphones for that. And everybody online, if you can type in questions, I'll make sure that we answer them. There is the opportunity to unmute yourself, but we'll ask you to do that if you have a long question. So the other thing that people have said is that when you do come up to the microphone to ask a question, if you can just introduce yourself first, that would really help the people online know who's speaking. So with that being said, I think we can start off with our first presentation.
Okay, so let's get right to it. So I'm pleased to recognize virtually, even though she does live a few miles away from us here, she is on the East Coast, Kara McDermott. Kara is a K-12 scholar in the UW Implementation Science Training Program, an acting instructor in the Cambia Palliative Care Center for Excellence at the University of Washington. She also will be starting this year as a new assistant professor at Duke in the Division of Geriatrics in the School of Medicine. And she'll also have an appointment there in Population Health Sciences. So congratulations, Kara. Wonderful, wonderful news about that. Today, she's going to be presenting on using implementation science to facilitate de-prescribing for multi-morbid adults with cancer. Kara, over to you.
Thank you. Thank you. It is lovely to be here virtually with everybody. I'm a pharmacist and trained in implementation science and clinically trained in geriatrics, oncology, and palliative care. I'm going to briefly talk about multimorbidity and polypharmacy as it impacts patients with cancer, and then move on to de-prescribing and implementation science. Next, please. Next slide.
There we go.
Thank you. Multimorbidity is present among 50% or more older adults in the United States. Now, these data are a few years old, and the number is now higher, closer to 60%. Multimorbidity onset is dropping also. Next slide, please. With multimorbidity disproportionately impacting Black Americans with a younger age of onset and higher number of chronic conditions. This also emphasizes the need to address the impact of systemic racism on health disparities and outcomes. Next slide, please. When addressing multimorbidity, we need to consider life expectancies as well as patient goals. Specifically for those patients who may not be at the end of their lives, but also have multimorbidity, whereby, for example, their cancer may be responding to treatments, yet their heart failure, for example, is negatively impacting their ability to receive treatments, it's very important to bring in care planning and to start to discuss how multimorbidity may be affecting their cancer care trajectory. Next slide, please. Multimorbidity is highly prevalent among patients with cancer, with the most common comorbidities being heart failure, chronic obstructive pulmonary disease, cardiovascular disease, diabetes, and hypertension. Patients with lung cancer are those most affected by comorbidity, with 76% of patients reporting 2 to 3 or more chronic conditions. More than half of patients who enter the survivorship phase have multimorbidity, although many previously did not have multimorbidity. Next slide, please. Oh, one back. Multimorbidity and polypharmacy go hand in hand. Unfortunately, among patients with cancer, both predict rehospitalization. In one meta-analysis, polypharmacy was associated with mortality, hospitalization, treatment toxicity, and postoperative complications. Now, one may ask, is it truly polypharmacy, or is it in fact that polypharmacy is a surrogate for poor health and multimorbidity, which may be leading to these outcomes? In these studies, they did in fact control for severity of disease and number of different comorbidities. Importantly, Yale Schenker and colleagues at the University of Pittsburgh have analyzed the impact of polypharmacy on quality of life and patient outcomes, noting that the number of medications is associated with medication side effects, which also predict poor outcomes. Among patients with cancer, it's estimated that up to 10% of medication-related costs are attributable to potentially inappropriate medications. I'll describe those in the coming slides. And I will answer the question of, is there a definition for multimorbidity or a tool for that? Typically in comprehensive geriatric assessment, which I'll talk about next, we do use the Charlson Comorbidity Index. Common definitions are 2 or more chronic conditions, such as hypertension alongside heart failure. However, there is also a greater degree of multimorbidity, which is 5 or more chronic conditions, and that's also on the rise, with 30% of older adults experiencing that. One thing that has been noted is that polypharmacy is often perceived as something that persists and is initiated with intravenous chemotherapy and older cancer therapies. However, polypharmacy is present with newer therapies as well. It's significantly associated with hospitalization among older adults taking TKIs, and 77% of older adults treated with immune checkpoint inhibitors had polypharmacy, and 50% of the drug-drug interactions detected are categories D or X. Now, with drug-drug interactions, you have they range from A to D and then X, with X being the most severe. So 50% of these drug-drug interactions would be rated as severe or absolute contraindications. Next slide, please. It's also important to note that polypharmacy is not only experienced by those who are older. Younger cancer survivors also experience polypharmacy, with 31% of AYAs having it after active treatment. Survivors of childhood cancer are prescribed many chronic medications to address the after effects of cancer treatment and develop polypharmacy, with this increase being most notable among those with CNS cancers or who received a transplant. Next slide. What is inappropriate medication use? And this really runs the gamut. It can include incorrect frequency, dose, continuation, or formulation. For example, somebody taking a medication BID instead of once a day, a dose that may no longer be appropriate for somebody with declining kidney function, continuation such as proton pump inhibitors used after hospital discharge, or formulation, for example, extended release versus immediate release. Perhaps the expected benefit of a medication is no longer aligned with life expectancy or patient goals of care, or the indication is not aligned with underlying reasons for use, for example, off-label use without a strong evidence base. Next slide, please. The most commonly inappropriate used medication among patients with cancer is this list here: antidepressants, aspirin and anticoagulants, beta and alpha blockers, diphenhydramine, proton pump inhibitors, statins, and vitamins and minerals. I want to note that this is really a gamut where you have vitamins and minerals and over-the-counter Benadryl. These are available over the counter, no prescription needed. You may not be aware your patients are taking them. And they're commonly perceived as no big deal. However, the potential problems with these are still significant. And then, of course, on the other end of the spectrum, you have anticoagulants that may contribute to things like a significant GI bleed. Next slide, please. In addition to the most commonly used inappropriate medications, we need to think about de-prescribing and how that may be affected by over-the-counter medications or other things that patients may obtain, for example, over the internet. I want to emphasize that de-prescribing is a process. It refers to the thoughtful and systematic process of identifying problematic medications, and it is not solely about stopping cold turkey. It involves reducing the dose, switching to perhaps a different drug class, or stopping the medications in a manner that's safe and effective. So, for example, proposing a taper for patients who are taking benzos. Next slide, please. Any time in the cancer care continuum is appropriate to consider de-prescribing. At diagnosis, with a geriatric assessment to note things like polypharmacy, nutritional status, frailty, and cognition, to assess chronic medications and see if patients are taking them or need all of them going into the treatment phase, to note drug-drug interactions during treatment and supportive care medications that may be begun and not necessarily stopped. As patients move into survivorship, addressing the need for perhaps changes in chronic medications, and also to address post-treatment effects. Palliative care referrals, I should emphasize, are appropriate at any time in the cancer care continuum, but are especially helpful with issues like chronic pain and depression following cancer treatment. For end-of-life care, we know that many patients who are eligible for hospice do not enter hospice until the very end of their lives. De-prescribing gives a chance to optimize quality of life and minimize costs, potentially reducing drug-drug interactions for patients prior to hospice entry. Next slide, please. De-prescribing can occur across cancer care delivery settings. This is a list that Whitman and colleagues have compiled of existing de-prescribing interventions in the cancer care delivery spectrum, with academic medical centers, surgical oncology settings, infusion centers, community hospitals, hospice, and specialty pharmacies being among the list of places where de-prescribing has been performed. Next slide, please. Now, I briefly mentioned comprehensive geriatric assessment. This can detect polypharmacy and prevent potential drug-drug interactions. CGA is recommended per ASCO guidelines and the International Society of Geriatric Oncology. In one study published in JCO Oncology Practice, only 53% of oncologists were aware of CGA guidelines. Of those who use it, less than half assess patients regularly, and falls in functional status are most commonly assessed. CGA can help identify frail or undernourished patients who are at greatest risk of poor outcomes. And in one study, it uncovered 74% of patients at risk for a moderate or severe drug-drug interaction. So going back to what I had previously noted, this would be categories C, D, or X of drug-drug interactions. Next slide, please. Including a pharmacist and polypharmacy questions in CGA can decrease drug-related problems. We've had a few studies now that have incorporated this with work from Erica Ramsdale and colleagues at the University of Rochester in particular. They've noted that among patients with cancer, 80% had polypharmacy. However, after pharmacist involvement, you see a lower number of medications used and fewer inappropriate medications. In another study, geriatric assessment-driven discussions facilitate discussion on medication management, supportive care, and total number of medications. Next slide, please. De-prescribing at end of life also has a particular importance because as organ failure increases and frailty increases and patients become more susceptible to delirium and falls, it's particularly important to keep reassessing their medications. The OncPal tool is specifically available for de-prescribing in this population, although other tools such as the Beers criteria, start, stop, and medication appropriate index can still be used. Discontinuing chronic or preventative meds are particularly important at this point because there is limited benefit, and in addition to that, there is a potential for harm as the patient moves closer to dying. Next slide, please. Now, implementation science. I've told you a bit about the problem and about the potential tools we have to address the problem. Implementation science is particularly interested in the barriers and facilitators to de-prescribing among patients with cancer. We want to assess what the attitudes are towards de-prescribing, as well as current interventions and how feasible, appropriate, and acceptable they are. Additionally, we want to assess the adoption of such interventions, the penetration. For example, is it only being used in the GI clinic? Are people in the CNS clinic or lung clinic willing to adopt this? The sustainability of the intervention, how long are we using it for, and do we have the money for it? Where cost also becomes a key consideration. Next slide, please. The quick breakdown of implementation science, for those who may not be familiar with this, is that in implementation science, we're looking at an intervention, practice, or innovation. Here it would be de-prescribing. In clinical effectiveness research, we're looking at whether the thing works. So that would be de-prescribing. Does it reduce potential side effects and potentially inappropriate medication use? In implementation research, we're trying to figure out how to help people best do the thing, or de-prescribing. Implementation strategies are what we do to help people do the thing, and the main implementation outcomes are how much or how well we do it. So is it feasible? Does it have widespread adoption? Is it being used with a fidelity to the original intervention? Next slide, please. De-prescribing relies on multiple inputs, and this is a conceptual framework of de-prescribing, which allows us to apply implementation science principles to assessment of de-prescribing and the intervention in practice. We need to specifically look at individual level factors at the patient level and prescriber factors at the individual level. But we also need to address system factors. All of these are inputs into the de-prescribing process that in turn affect our effects and measures and our ability to disseminate de-prescribing interventions. Next slide, please. Now, how do patients and caregivers feel about de-prescribing? This goes back to the barriers and facilitators I previously mentioned. Patients and their caregivers value medications that are effective, that are prescribed by a trusted provider, that promote quality of life and lower cost. This goes back to the issue that many existing interventions are what I call the drop and go consult, where somebody looks at a medication list and says, this should come off. Without an established relationship with a trusted provider, that intervention will likely not work. Next slide. Caregiver involvement in de-prescribing cannot be emphasized enough when caring for patients with cancer. Caregivers often have strong feelings about the necessity of medications and medication burden. Caregivers often play a significant role in patient medication adherence and patient preferences about medication use. And shared decision-making is valued and necessary. If a caregiver is involved in medication administration or choices about medication use, they must also be involved in de-prescribing. Caregivers often derive a significant sense of self from helping patients in cancer treatment, and also may be invested in patients taking their medications as a sign of continuing care. Next slide, please. Well, what do prescribers think about de-prescribing? This is notable that primary care should take the lead. This is a common response. And in oncology, this is particularly challenging because during active cancer treatment, the oncologist is typically the source of information and all care coordination for the patient. Prescribers think that collaboration across disciplines is needed, patient caregiver input is needed, and de-prescribing should be tailored to patient needs. Additionally, and possibly the most important, is that de-prescribing involves swimming against the tide of expectations and clinical momentum disruption, which can be incredibly difficult. Next slide, please. With respect to systems barriers, we know that lack of time and space and interruption to workflow are important barriers. Additionally, there's lack of incentive for de-prescribing and a concern about malpractice and fractured systems that do not communicate with each other, specifically EHRs and different systems of care. Next slide, please. Common barriers to de-prescribing per prescribers who want to de-prescribe are time and knowledge of de-prescribing. Concern that when we take off a medication, we don't necessarily know what's going to happen. Fear of alienating patients, that patients may perceive this as giving up. Professional courtesy. For example, I didn't prescribe it, so I'm not taking it off. Again, clinical momentum, in that we are used to prescribing medications. And sometimes when there's a side effect of that medication, we prescribe another medication, which can result in prescribing cascades. That's typically the way that we have handled these things. Additionally, gaps in communication and care coordination are important and leave prescribers with a lack of knowledge that therefore undermines their willingness to de-prescribe. Next slide, please. Now, I want to briefly talk about loss. De-prescribing and de-implementation involve a sense of loss for patients. They don't want to feel abandoned, and clinicians are accustomed to prescribing. Medications have greatly advanced cancer care delivery, and we are used to being able to provide patients with a medication that will help them. And the sense of loss that comes with de-prescribing can be mitigated by substitution. It is important to present de-prescribing in terms of a continuum of care, that the medication we gave to you previously may no longer be the right medication for you now. And that while we are not peeling off all things, and this does not mean we are giving up, rather, we want to make sure to tailor a plan to you. In terms of substitution, mitigating a sense of loss can be taken apart by offering other interventions or medications. So for example, a patient who takes benzodiazepines as needed for sleep, but is also taking opioids, an SSRI, and another CNS active medication, trying to take away the benzodiazepine is important. But offering substitution with non-pharmacological care may not be sufficient, especially for patients who have taken these medications for a long time. That is where substituting in another medication from a different drug class may be appropriate, or speaking around cognitive behavioral therapies and other support options. And then coupling implementation with de-implementation is also important. Now, Christian Helfrich here at the University of Washington and colleagues have talked about how physicians often experience a sense of identity crisis or loss when talking about de-implementation, because that is not what is the norm, especially in cancer care delivery. But if we can couple the implementation of a new substitute or a new paradigm or a new plan with that de-implementation, de-prescribing tends to be more successful. Next slide, please. Now, we need future research on polypharmacy to help tailor these interventions and make de-prescribing more successful. Nightingale and colleagues have noted that we need more on polypharmacy methodology and definitions, and a focus on comorbidities and geriatric syndromes, as well as the effectiveness of polypharmacy interventions. Next slide, please. With respect to implementation science and de-prescribing, we know what the barriers and facilitators are. How do we address them? Well, one is multi-level interventions. NCI has a fantastic training institute on multi-level interventions, and the optimization of interventions before randomization can further the field of de-prescribing. Specifically, what are the optimization factors we need to consider to meet individuals where they're at and tailor de-prescribing, incorporating shared decision-making and individual characteristics. With optimized interventions, we can then test them in hybrid trials. There are trials that are hybrid type 1, 2, or 3, which have varying percentages of emphasizing testing implementation along with clinical outcomes. Finally, we need to measure cost and sustainability. A reference below with Heather Gold and colleagues is a paper that we recently published in conjunction with NCI at the Dissemination and Implementation Science Conference around how to approach costing interventions and how to advance economic considerations in implementation science. Next slide, please. With that, this is my presentation, and I greatly appreciate the chance to present to the SWOG group. I'm happy to take any questions, or please feel free to contact me via email or on Twitter. Thank you for your time.
Thanks so much, Kara. That was an excellent presentation. I feel like I get to give the first question since I'm a primary care provider. And I actually have a little case I want to share with you to see what your response is. So I recently inherited a patient who, a 74-year-old man, was diagnosed with a glioblastoma. He was, during treatment, suffered severe hypotension, was put on a number of pressors. His chronic medications include an antihypertensive, cholesterol medication, PPI, and I think an SSRI. And, given his prognosis, I started the process of de-prescribing most of those medications. But what I found that he and his wife had thought about with those medicines is most of those he'd been on for a long time. And his previous providers had told them that they were going to improve his health. They were going to have him live longer and better. So he associated his antihypertensive and his statin with good health. And by de-prescribing, I think the implication was that this is not good health. This is harming him. So how would you go about addressing that particular perception among patients who are really not benefiting from those medicines?
Absolutely. That's a great question. And it comes up all the time because many times when we present patients with medication, it's for their good. But one of the things that I have found particularly helpful is to frame it in terms of, at the time, this was necessary to help you because you had high cholesterol, you had hypertension, but the current state of your health has changed. And this doesn't mean that we're not going to treat things anymore, but at this point, we have to look at benefits from these medications and harms. And typically for somebody who has received these in the past, we give that to increase health. But there's always a double-edged sword with medications where sometimes medications may not help you, but actually may harm you. And what I have said is, I'm worried. I use a lot from my palliative care training in terms of, I'm concerned that this medication is no longer helping you. I'm worried about the potential side effects for you. And one of the things that I often do with patients is sit down and ask them, what's the most important thing to you? If we could do one thing to make sure that you can still do X, what is X? And so, for example, for a patient who was very, very invested in taking lisinopril, but was experiencing orthostatic hypotension and falls, it was something that we were able to peel off after I explained that if you have a significant fall, you'll no longer be able to go to your grandson's baseball games. And that's the thing that you've identified as most important to you. So with the change in your health, we need to address this and figure out how we can align your goals. But it's difficult because most of the time patients and our health system are incentivized to take medications because we associate medications with health. So I do sympathize with that. And I would suggest that with goals of care and acknowledging that perhaps this medication is harmful, not helpful anymore, that we need to just change game plans. Additionally, for patients who are taking things for a very long time, a slow decrease is usually something that can get them on board when they see that there's no harm as they start to decrease it.
Great. We have a bunch of questions. So just to try to stay on track, do you want to ask your question? Just to introduce yourself first, if that's okay.
Sure. My name is Dr. Lisa Go. I'm an internist, internal medicine in Temple, Texas, the Baylor Scott and White area. And the question, there were three things actually I wanted to ask. And this is dedicated to the people of Temple, Texas, because I see the uninsured and underinsured poor of Temple, Texas and East Bell County. First of all, it is very difficult to de-prescribe because there's a lot of emotional invested into it. And we've been trying to de-prescribe the last 25 years, and we've been discussing this since 2000, and it's just been difficult. Have you ever tried doing a lifestyle prescription instead of a pill prescription? Have you ever tried doing a compassion prescription instead of a pill prescription? Have you ever tried to do a nature prescription instead of a pill prescription? These are concepts, ideas that I have to acknowledge that my colleagues at Baylor Scott and White are looking into very heavily, and other physicians are doing that. It's through the lifestyle measurement and also coming out of MD Anderson and Compassionomics. And that way we are able to exchange out something for something.
Mm-hmm. Absolutely. So my understanding is that your question is, trying something that is non-pharmacological. And I think that's quite important. But one of the things that we need to acknowledge as clinicians is that oftentimes patients are taking medications because we are not meeting their basic needs or social needs. And that's something that is outside the field of medicine. That many times patients, yes.
But okay, so we feel at Baylor Scott and White that is part of medicine and coming out of the internal medicine. So I see that it has not been, because we actually have it documented that if you do like meditation 30 minutes a day for 5 days a week, that is a dose that will affect. And so thank you for your answer.
Sure.
So Ray?
Hi, Ray Osaro-Diago. I'm a thoracic medical oncologist, sort of a card-carrying applied implementation scientist. Great talk, really enjoyed it, very instructive. Big topic. As a lung cancer medical oncologist, yes, indeed, we see this as a huge problem. I'm struck though by one of the observations that physicians are used to prescribing, and that backing away from that may be something that we struggle with. I wonder what the evidence for that is. Yes, indeed, we see that polypharmacy is a huge problem, happens all the time. We deal with this all the time. Do we really have evidence that physicians are reluctant to back off of medications? Certainly medical oncologists, I think, are fully aware of the problem of polypharmacy, and we deal with this all the time. I guess where I'm going with this is one of the points with implementation science, of course, is to be able to do barrier analysis, to be able to understand when you try to do something in a real world environment, what works, what doesn't, and try to figure out why things work and don't work. And I think it'll be very important that when you do the studies that you propose, to be able to interrogate that, because what you don't want is to expend a lot of time and effort in a solution that doesn't really meet the problem.
Absolutely. So to briefly answer your question, we do have a surprising amount of data that shows that people are very reluctant to not prescribe medications. And this data largely comes from Emily Reeve and colleagues, Christian Helfrich and colleagues, the De-Prescribing Research Network, which is, I believe, deprescribingresearch.org, also has a lot of great references there. And one of the things that I think is important is that medical oncologists are certainly recognizing that things do not always need to be prescribed and that there are alternatives. But if you are squeezing multiple patients into your day, you have 15 minutes, and there are significant barriers to either deprescribing or addressing a multifaceted symptom or issue. The way that our system is set up is that it incentivizes the prescription. And so we need to think about deprescribing holistically as a multi-level, multi-system intervention. And we need to also address the concerns that physicians have around knowledge of deprescribing, potential for malpractice, dropping clinical momentum, and patient feelings of abandonment.
So with that, I think we're going to need to move on. But what I want to do is have everybody, think about how to use this to design, either an intervention or another observational study or implementation study of deprescribing, because this is a critical issue for cancer care delivery, especially with a lot of the oral medications that are on the rise for cancer care. There are an enormous number of drug-drug interactions, and not all sites have on-site pharmacists to go through these things with patients. So it's a critically important area that I think we should, try to move forward in SWOG.
Thank you, Kara.
Thank you.
All right, we're going to now move on to the second presentation portion of the meeting this morning. We're going to have a panel on recruiting patient caregiver dyads, strategies and challenges, followed by a panel discussion. Our 4 panelists include Dr. Veena Shankaran at the University of Washington, Dr. Daniela Whitman, University of Michigan, Dr. Christine Veenstra at University of Michigan, and Lee Jones, who is a SWOG patient advocate. I believe Veena is the only person who
Nope,
is,
and-
oh, nope, take it back. Lee is here, excellent. So we've got two here and 2 remotely. And I believe we're going to start with Veena. Okay, let's get you rolling here.
Great. Thank you so much for that introduction. It's wonderful to be here and to see so many familiar faces that we haven't seen in a few years. This panel was really just sort of came out of the fact that we now have a couple of dyadic studies taking off within SWOG, so the credit trial, which I'll talk about in just a minute, and Dr. Veenstra's work on colorectal cancer surveillance. And so we wanted to take an opportunity to kind of dig a little deeper into dyadic research, really to talk a little bit about what it is and why it's important. Obviously review the studies that are up and coming in SWOG. We wanted to hear also from Dr. Whitman, who's an expert in dyadic research around her experience from a study promoting sexual health in couples coping with prostate cancer. And then really learn from Lee about his perspective as a SWOG patient advocate around considerations for including Dyads in research. So what is the basic case or background for dyadic research? So I think we can all recognize that cancer really affects more than just the patient. It affects spouses, partners, and other informal family caregivers. And the Institute of Medicine highlights the importance of involving family members in patient-centered care. In terms of dyadic research and interventions, there are lots of potential benefits. And a key aspect of this kind of research is that it treats patients and caregivers as one unit of research or one unit of care. The benefits include decreasing negative appraisals of illness, improving symptom distress, improving dyadic communication about cancer. And there is literature on how communication can actually impact downstream outcomes, psychosocial and health, increasing support and resources for support, and improving self-efficacy and healthy behaviors over the course of disease and also into survivorship. Next slide. So with that in mind as our sort of background, I wanted to talk a little bit about the credit or S1912 CD study, which most of you are now familiar with, but really wanted to focus on the schema here. Next slide, which is the this is a kind of true dyadic study, and that the goal of the study is to deliver financial navigation intervention versus control to patients and spouse caregivers. So not only are the patient and spouses enrolled as a dyad, as a unit, so we are not enrolling patients without caregivers, we're not enrolling caregivers without the patient. So both parties have to be enrolled as a dyad. Both parties receive the research intervention as a dyad, as a unit, and the outcomes are measured at the dyadic level, but also at the individual level. Next slide. So here is a slide just showing the main outcomes of the study, the endpoints. So the main primary endpoint of the study is actually household financial hardship. So you can see that this endpoint is measured at the household or dyad level. We're looking at various evidence of various financial hardships in credit records, and also including some questions in both the patient and caregiver questionnaires as well on this. But there are also a number of secondary endpoints, both at the patient and caregiver level. So it just gives you a sense of what we're doing and why understanding the importance and how to approach dyadic studies is important for enrollment on this study. And I'll just mention that we will have a panel at 1 o'clock, roundtable, kind of digging deeper into the study and sort of recruitment challenges and potential solutions. So if you're able to come, you can come to that later. Moving on. I'll turn it over to Dr. Veenstra now, who'll talk about her colorectal cancer surveillance study.
Thank you very much. And thanks everybody.
I'm very sorry not to be joining you in person today, but happy to be here virtually. And I think most of you have probably heard me talk before about this study to develop a multi-level intervention to promote guideline concordant colorectal cancer surveillance. So I'll review briefly today. Next slide, please. So the components of this intervention, there is a component, a dyadic component, which is at the level of patient and their partner. It's a spouse or other intimate partner. And it's an online module that we've developed that has both dyadic and individual components. So we provide education about colorectal cancer surveillance, and that's done at the dyadic level. We elicit individual preferences from the patient and their partner separately, and these are preferences for how the partner should be engaged in the process of colorectal cancer surveillance. Then we bring patients and partners back together for a dyadic module about communication training, and it's communication around their preferences for how the partner should be involved in surveillance. And then finally, we present Dyads with a tailored checklist of consensus activities. So this is a checklist that's generated based on the individual preferences that are elicited to help Dyads come up with some activities they could participate in together to help get on the same page and communicate about their preferences for how partners could be involved in the patient's colorectal cancer surveillance care. We also plan to develop a clinician level component of the intervention, which we anticipate would be a module within the electronic health record, which would provide tailored feedback taken from our dyadic component to clinicians about who the partner is and what that dyad's specific preferences are for how the partner could be engaged in the patient's surveillance care. And then provide some brief tailored training to the clinician about how best to facilitate engagement of that partner in that patient's care based on that dyad's specific preferences. Next slide, please. Next slide. Thank you. So we have been piloting the intervention at the Rogel Cancer Center. We started piloting at the end of June. Our recruitment goal was 10 to 12 dyads to complete the module and a follow-up survey, a very brief email survey. We are recruiting patients with stage 3 colorectal cancer within 6 months of treatment and their spouse or partner. We have been inviting patients via letters that are sent either in email or postal mail. We have not been able to recruit in person in clinic as of yet. And both the patient and the partner receive a $10 gift card upon completion of the follow-up survey. We've invited 58 patients total so far to participate, 21 female and 37 male. 17 people have visited the intervention website. We know that 9 patients have initiated the intervention, 6 female and 3 male, and similarly 9 partners have initiated, 3 female and 6 male. And only 2 patients and 3 partners have completed the follow-up survey. So the recruitment has been unfortunately a lot slower than we anticipated. And I think in the rest of our discussion and with our other panel members, we'll touch on some potential reasons and some ideas around recruiting for dyadic studies. Next slide. And now I'll turn it over to Dr. Whitman.
Well, thank you very much for the invitation to participate on this panel. So I am a sexual health researcher at the University of Michigan in the Department of Urology, primarily in the prostate cancer survivorship, and all my research has been done observational and intervention with dyads. I do mixed methods research. And we designed and developed and then tested in a randomized controlled trial an online intervention for couples, supporting them in their sexual recovery after prostate cancer treatment. This was focused on patients with localized prostate cancer, and the intervention was tailored to partnership, sexual orientation, and treatment type. So I want to note that these next two slides are animated, so thank you for starting with this. We were able to screen and find 1,099 couples that were eligible at the 6 sites, but we were not able to approach all of them because somewhere in were in such outlying clinics that the coordinators were simply not able to reach everybody. So we had over 500 patients and their partners that we approached, of whom 288 declined. Click next, please. The reasons that they told us that they declined were primarily that patient and partner were not interested. Secondly, the patient was interested, but the partner was not. And the third most important reason was that the couple was not sexually active. And then if you can click on the slide again, we were able then to recruit our 142 couples, and they filled out a survey at baseline. And then it's 3 months after the end of treatment and 6 months after the end of treatment. And you can see quite significant attrition. Next slide, please. So the lessons that we learned from our study were that our recruitment rate was about 44%, which was reasonably in line with other studies that we have done at the University of Michigan on sexual health, and these were all dyadic studies. We found that the attrition rate was about 46%. Again, this was in line with other studies that offered online interventions, not all in sexual health. We found that partners were the ones that were more likely to drop out. And we considered that patients and partners may have had very different motivations for consenting to participate in the trial. And we did not assess that. We did not really understand that. I can tell you from my prior research that at least in prostate cancer, often the men would say that their partners knew them better than they knew themselves. And so they were very glad to have the partner participate. And the partners really appreciated being included. So there was really a desire to participate, but perhaps for different reasons. We found that in our sample, the partners who tended to drop out were more likely to be employed. So there may be another sort of way in which life interferes with participation in the trial. In the end, we concluded that it's important when recruiting patients and partners of family caregivers for trials, it's important to assess their motivation and goals for participation so that we can sort of keep up with them. We also need to be able to adapt the content of the intervention to suit what those motivations and goals are so that we can keep them in the intervention. So this is sort of a goal for the future. Thank you. I wanted to underscore the importance of including caregivers by this quote, which came up at the end of the trial when we evaluated qualitatively people's satisfaction. And this is a partner quote. This is both of our issues. So it makes sense to go through it together because then you try to solve the problem together. Thank you.
Next slide, please. I only have one slide after this. There we go. Thanks for inviting me to provide a patient perspective on this question. So my name is Lee Jones. I'm a research advocate. I'm on the survivorship committee. I'm also a stage 4 colon cancer survivor and sort of base some of my observations on that. My wife was my caregiver. And I remember times like after my liver resection, she would make me march around the ICU with my little stand with my bags of stuff on it. I said, just leave me alone. No, you got to walk around. You got to walk around. You got to blow into that thing so you get your lung capacity back. So there really are some real advantages to having, a dyad because we really do oftentimes operate together. But I think it's important to understand when it's good to use a dyad and when it's not really essential to do that. So for example, I was involved in S1820 doing the protocol development, and it's a dietary intervention for people with rectal cancer to reduce their after effects. And I suggested that we use dyads because if the patient is the main cook in the household, whoever they're cooking for has some input into that decision. And again, if they're not the main cook in the household. They're dependent on, telling that person, here's what you need to do to cook because this is what I need. Ultimately, it was decided not to go for a dyad. And as far as I know, there's been no real problem with doing that. It's expected to reach its accrual goal this month, which has been actually a very, very good accrual rate. So there's an example of when a dyad might have been useful and effective, but not having one, I think, simplified a lot of things, which I will talk about in going through my presentation. But I want to emphasize that I am in favor of using dyads where they are relevant to the research study itself. And the main thing that I've really thought about is that we tend to use, I think, a middle-class model of what a household looks like when we're coming up with these dyad decisions. So, for example, the eligibility criteria. I went through and looked at a number of studies online, and some required there be a minimum age of 18. Another one was a minimum age of 19. But, we probably know of situations where, say, someone who's not primarily English speaker, maybe their 5th grade daughter is really their primary caregiver, and their single family caregiver, a single mother. And so they don't have a traditional family like we think of as a family. And so why should we have eligibility criteria or exclusion criteria that may eliminate some very important families to look at and may end up reducing the diversity of our studies? So I think one of the studies we looked at was mentioned here, the couples have to be married, the caregiver has to be married. Well, that would be appropriate in some situations, but in other situations, could it be a partner? Could it be a neighbor? Could it be a grandchild? Could it be a son or a daughter? Again, I think we should avoid overly defining what this group needs to look like, because we're eliminating people who could participate in the study otherwise. So consider racial, gender, racial, and cultural differences. That really gets back to some of the eligibility criteria, but we also have to remember that not all families are traditional families, not all partners are traditional partners. And what sort of difference will that make? Will a homogeneous partnership, people from different cultural, ethnic groups will be able to communicate with that dyad as effectively as an individual person, where we can tailor our message to them, but we're telling a message to people who have different values, it might be more difficult to contact them. And remember, with the dyads, you're looking at really twice as many people to enroll, maintain, and follow through the life of the study, which will add some difficulty, I think, to the analysis. So the best point of engagement. So, coming to a clinic, you might have a patient coming in. They might come with a caregiver. They might come with a parent or a child or a family member, a friend, but you don't know that for a fact. So I think you reduce your ability to recruit people because it's harder to reach them as a dyad as two. Now you can approach the patient and say, would you bring in your caregiver? But again, you then have to be reliant on their definition of their caregiver and who they want to have participate in that study with them. It may not be the person that you've expected it to be. So again, just something to consider. I also think the question of what's in it for them is important to address. Yes, it may just be a love of the patient and the patient of the caregiver, but it's not always going to be that kind of a relationship. Particularly, you can imagine in some sort of exercise intervention, it may be an elderly couple and their spouse is not really able to exercise with them, so maybe they'd have the grandchild come in. If it's financial, it may not be a really a partner. So I have a friend, a Black woman whose mother is widowed, and so if they were to go, if the mother was going to go into a trial, she would bring her 50-year-old daughter as her caregiver or family member. You know, have you allowed for that, you know, in your exclusion criteria? So what's in it for them is a lot of matter of how will this trial, how will the study possibly benefit the person that you're caring about? And also in many cases, it would benefit you as the caregiver as well. Like with exercise, we know that, nutritional interventions, we know that. Financial intervention, you know, if the household finances are in better shape, it obviously benefits everyone in the household. But will their other be a family member or not? Again, we can't guarantee that that's going to happen. And so we have to, I think, as they oftentimes say, meet them where they live. Or don't assume that you understand, you know, who your potential participants are going to be in the study. And then no matter who you end up getting, you have to actively engage and communicate. Certainly, at the minimum, have a periodic newsletter so that people feel like they're part of something. Because remember, even though we think that, well, yes, my caregiver is going to keep me motivated, that's not always going to be the case. I mean, you have twice as many people that you have to keep engaged in the study, and either one of that in that dyad can say, nah, I've had it, and you lose them both. Other things might be having groups get together, having different dyads meet each other so they feel part of a social group, but you have to make sure that's not going to affect the results of the study. So anyway, those are some observations that I've made as a patient who's gone through this process. Might be a little bit different than what the scientific findings would produce, but my main message is don't assume that you know who your patients are. They could be any sort of a grouping that you can imagine, and try to allow for that, because we don't want to exclude people because they're not like us. So thank you.
All right, well, we're going to have a very brief discussion section. And
Yeah, I think in the interest of time, we'll keep this pretty short. We're going to have some Q&A, but I think any of us would be happy to take questions offline as well. I think the key here is that we wanted to emphasize that dyadic research is really important because it's kind of a unique perspective that you can't get by just simply including patients. I think to Lee's excellent points, it's really critical that we, where it allows and where it is appropriate to the scientific question, also try and think creatively about what that dyad looks like. And I think the other points we heard is that dyadic research is really challenging and there's high attrition rates. And so, you know, to Lee's point, it's also really important to think whether, to think about that and to think about whether the dyad is critical to the research question, because it may not always be. I think just from a practical standpoint, as we kind of get more dyadic studies, hopefully within this committee, I'd love if we could hear from Drs. Veenstra and Whitman about their processes for identifying and approaching dyads in the clinical setting, and how they've addressed the problem of attrition, or how you kind of balance maybe differing or different interest levels and motivation to participate in research from the patient and caregiver.
Dr. Whitman, would you like to answer first?
Sure. So just in terms of identifying, it has not been that difficult for us to identify dyads because many patients come with their partners to clinic appointments. We also have coordinators screen surgery and clinic schedules, intervention started before surgery and radiation treatment. So we screened, and the coordinators called the patients and solicited the partners as well. You know, I think that in sexual health interventions, we will run into barriers that perhaps you won't in others. But I think I really am appreciating Lee's comment about what's in it for them, because I think we're finding that partners can get kind of exhausted over time in being the support person. And we need to think about what it is that we want to offer them in the participation in the research that perhaps we don't consider enough. In terms of keeping people in the research, it's sort of what I said when I spoke, and that has to do with ongoingly assessing their interest, their engagement, and their reasons for disengagement, so that we can understand better how to keep them motivated. I think this is an answer we don't yet have.
And I would just add to the point again about the sort of different goals of patients and partners in research and what's in it for the partners or the caregivers in research. We've done some qualitative work, and many of the partners that we've talked to have mentioned the idea that it can become very overwhelming, and they feel like they get lost a little bit doing everything to help take care of the patient through their cancer diagnosis and survivorship, that their own wellness gets lost, but that it's really important to keep up on that so that they can continue to help caregive for the patient. And so one of the things we've thought about doing is adding a module into our intervention that is focused just on the caregiver and talks about resources for the caregiver and ideas for caregiver wellness. So an idea of something that might be appealing to caregivers to get a little extra support just for them in these dyadic interventions.
Can I just add to that?
I just want to ask anybody in the audience who has been enrolling in credit or has experience with any dyad enrollments, like what types of strategies have worked. I know I don't want to put our team at Columbia on the spot, but it's a unique thing for us to approach both the patient and their partner, and what's been useful so that everybody else can learn from your experience.
Volunteer.
So at Columbia, in our breast clinic, which is nearly all female patients, I think the challenge has been like, not all the women have a spouse, or like they're divorced, they're widowed, et cetera. And then even when they come with their spouse, sometimes the patient wants to participate, but the spouse is reluctant to give their credit reports or do the other study intervention. So that's been our main barrier.
Can I just add something to what Dr. Weenstra said? I think the idea of adding a module for caregivers themselves, I think is really a very, very good idea. We did a study asking patients and partners what they want from interventions, and this is exactly what partners wanted. We actually did have that in our intervention information specifically for partners, but I think perhaps more is needed. They really wanted to have access to other partners. So mutual support, I think, can be extremely important, and not sure how you would put that into your research protocol, but not feeling alone and feeling like there are others who are coping with the same thing, which is not the same thing that the patients are coping with, can be helpful.
Go ahead.
Hi, so I'm the research coordinator for Dr. Hirschman's credit study at Columbia. And I think one thing that's important to keep in mind here is how much trust the patients put in the physicians versus maybe the research team in general. Patients and their spouses put a lot of trust in you guys. You obviously have a lot of contact with the patient, but not maybe always so much with the spouse. So maybe just getting a direct line with the spouse at any point, whether it's over the phone or at a visit, I think that would be very helpful for enrollment, just because they do trust you guys a lot.
And just to add on to one thing, I'm the clinical research manager at Columbia for NCI and then for breast oncology. We recently tried to engage with our social workers in New York Presbyterian and then Columbia as well to work on to recruitment strategies for this study. And it was very interesting that we thought our social workers would be a bit more receptive to a free intervention that would be helpful to their patients and to the services that provide. They were a little bit more combative than we anticipated because they didn't see the importance of the dyadic portion of it. And we had eventually spoken to the Sense and the other group, and we kind of wish that we had spoken to them prior to the speaking to the social workers who explained to us a little bit more precisely why it's an important as well. We mentioned this, the information from S1417CD as to why it was so important that now the credit study requires both. We're still looking to engage with them. We're kind of have them on a little bit right now, but we're hoping that maybe if we can keep pressing them, that they'll open new opportunities for to refer to us patients for the credit study.
Yeah, thank you so much. We actually heard that the social worker had met with SEDS and PAF or talked with them. Hopefully that was helpful. We are also happy if this comes up at any of the sites that maybe the internal financial counselors or social workers are kind of confused about whether the intervention will sort of step on their toes or even the importance and relevance of the research. We can happily set up meetings if needed.
So one thing that we've done or gone away from is using the term caregiver, because some people get indignant by that. I don't need a caregiver, but they have a support person, or there may be other terms that people use. So we approach people in that context, and just as Leo alluded, it could be anybody. It could be a younger person, an older person, whoever that person may be that they feel closest to that really helps them, or maybe going through this journey with them. Or there may be more than one person, of course, too. But who is that target person?
That's actually a really great point, because sometimes we don't even think about how, we always say words matter, but that kind of terminology might really make a difference. So I really appreciate you bringing that up, because sometimes we just don't think about how our terminology might affect people. I know myself from doing a lot of work on medication adherence, most patients cringe when they hear that word non-adherence. So sometimes, what we're so used to hearing, really can come across a different way from the other perspective.
And in the case of credit, for example, the spouse may not actually be the primary caregiver bearing the brunt of all the caregiving duties. So that's a very valid point.
So a couple of comments just from the chat. One was suggesting to increase the reimbursement for the dyad versus single. And another was in the Midwest that often folks are not comfortable talking about money. So that's a kind of being from the Midwest, I'd agree with that. It's sort of it's a cultural issue. We don't talk about a lot of our feelings in the Midwest. So
I will say the Midwest did great enrolling to S1417CD. So
we can overcome those.
Yes.
Things, I think. Again, Vina, do you want to just let everybody know where the smaller group session is?
I don't know.
Oh,
it's in this building somewhere.
Hold on.
What? 401, room 401.
Yeah. Okay, so
and that's from 1 to 2.
Interested, please come and share your experiences as well with that. I think with that, we're going to thank our panelists for coming, and I think that worked out really well. And I also know that Barbara Segura, our patient advocate for cancer care delivery, came in because she had a conflict. And so we want to just thank her for all of her involvement in the development of all of our protocols. We're super appreciative of all of her efforts on this committee. So just thank you, Barbara. I don't know.
Let's welcome Jens Reuter, who's going to talk to us about 2108 CD, cluster randomized trial comparing educationally enhanced genetic tumor board intervention versus usual care. This one's a long time coming, and we are very glad you are here.
Well, thanks for having me. And it's actually great to be here in person and not just have a Zoom call. So as the agenda says, this protocol has been approved. It's currently undergoing IRB review, and we hope to have it activated by July, August, somewhere in that time frame. And some of you, or many of you in the room, we've been in communication with, and there is also a breakout session, and I think there's a slide on that. It's at 2 p.m. It's, I think, room 302, and it will also be on Zoom. So I will just review a few highlights here, and then there are more details later. So this is the schema. It is a cluster randomized study, as the title says. It will randomize a total of 18 NCORP sites to either receiving this EGTB intervention or to follow through usual care. And our primary endpoint is the proportion of patients that start evidence-based genome-informed therapy. Next slide. So these are the primary and the secondary objectives. I already mentioned essentially the primary objective, just slightly rephrased. It's about identifying to determine what this evidence-based genome-informed therapy proportion is within 6 months after registration to the study. And then there's a number of other secondary objectives that are listed there. I won't read all of them, but you can see there are some physician-based primary endpoints and some additional patient-based primary endpoints as well, or objectives. Yep, next slide. There are also these implementation objectives. It's not a bona fide implementation study, but we think it's important to understand how, how such an intervention can actually be implemented in clinics and at sites. So just an overview, if you can go to the next slide, of the intervention itself. And actually, if you come to the breakout session, I decided actually to add a few slides there to actually show you how typically these genomic tumor boards actually run and how they work, and what's actually, what is the secret sauce essentially. We've been talking about this quite a bit for now, and we've made up this great term, evidence EGTB intervention, educationally enhanced GTB, but unless you see it, you won't really know. But the outlines are given here, and I think the bottom line really is that it's taking a deep dive into a genomic test report, dissects it, and then based on the genomic information that's on there, and we all know that these reports can sometimes be rather long and cumbersome to read, and then it will basically bring it back to kind of the clinical relevance and how can they be best applied to care and to informing therapy. And then there is supporting education. This is currently already, some of it has already been developed, others will be developed as the study moves on. We have a clinical education team at JAX that focuses really on this topic. How can you make genomics and genomic medicine more approachable, and there are many different modules that are being developed, and also types of different educational materials. Go to the next slide. So the eligibility, we coined this term Recruitment Center for really the one reason that a single NCORP can actually have multiple recruitment centers within it. We know that some NCORPs are rather large and have many different practices within them that sometimes are even different healthcare systems that are under one NCORP. So the definition is given right there. And it's, again, in the breakout session, we can discuss this in more detail. There are some, sort of shades of gray here, if you will, as we define this. But the bottom line is mentioned right there, that they have to essentially be have a CTEP ID number and so forth. But we can go into more details later. There's also a recruitment center application, which we're currently working on. And the magic. Oh, there we go. I mentioned some of this already. One other point that has actually already come up in some of the conversations that we've had is questions like, well, we have a molecular tumor board, or we're planning on, assembling one over the next year or so. Honestly, I think that will have to be very individualized conversations, because not all molecular tumor boards are the same. But there are, very clear sort of eligibility criterion is that you must not have a pre-existing genomic tumor board. And again, if there are any questions, I'm happy to, we're happy, either Magna or myself are happy to talk with you about that. There are some other kind of, basic characteristics listed there, primarily around, the types of physicians, the number of physicians, the willingness to register patients on study. And then also the other question that has come up is, if you're randomized to the intervention arm, these genomic tumor boards will take place on a regular schedule, and we really do need to have a representative of the practice of either the physician, him or herself, or a representative at these meetings, so that we can get the clinical context and also really deliver this intervention effectively. And it has been pointed out to us that the cluster randomized study, is a little bit unique and is different from other trials. So there are some expectations to sites. Require greater level of commitment from participating sites than any other sort of non-cluster randomized study. We expect that you commit for the duration of the study, which is approximately 36 months with all the patient follow-up that occurs. And then also, one of the, as I mentioned at the very beginning, this is a randomized study, and obviously, as is the nature with randomization, at the onset, we don't know what arm you will be randomized to. And so we really do need the commitment that even if you're randomized to the control arm, that you'll still participate and accrue patients and have your physicians participate as well, because otherwise, obviously, we cannot do the study. We will ask sort of for that commitment, as mentioned there. There is some additional, I'm not sure how much this is different from the prior slide, but basically, there are some documentation requirements as well. So we do want to know and document how many of these tumor tests you order as you go through the study. There are some interviews with physicians that we would like to conduct as part of the implementation objectives of the study. And, obviously then if you are assigned to the intervention, you are able to participate in these. And as I mentioned earlier, we actually expect that someone does participate in the actual meetings. And so there is the information. I think I was actually right on target. So from 2 to 3, which is I think the same time as a reception. So you can grab some food and then come to room 302. I think it's actually a fairly large room. So if you are here in person, I think there will be enough space to spread out, and then it will also be on Zoom. If you're seeing the study on the slides, well, actually you can't click on it because it's just on Zoom, but this is the meeting information. And if you require any other information, I'm sure we can get that to you. And some of you have already received an Outlook invite. So look forward to discussing more there, and happy to answer any questions here. These are our, we actually do have now these great email licenses, so you can either use that or email us directly.
So there are a couple questions on the chat, and anybody that has any additional questions, please come up to the microphone. But on the chat, one was that they hoped a secondary endpoint would be keeping track of geographic variation of the mutations. I don't know what your thoughts are about that.
Well, that's an interesting idea. So we certainly will collect the genomic test report data. And I know that there are some people that are interested in this. There are, let me just put it this way, there are other large, population-based studies that have been done or are being done that collect this kind of information. So our patient number at the very end may not really be all that relevant for that, but certainly an interesting idea and something to consider.
And the other question was wondering how, if you've already identified the sites, do you think you're going to be able to find the sites that you need? Maybe you want to comment on that. Yeah,
so we actually, as we were in the process of presenting this to DCP, we actually had a fairly robust list of sites that were definitely interested, actually wrote a letter that they would be interested in, opening the study. So based on that, and based on actual continuous communication that we've had, I think we will be able to recruit the number of sites that or recruitment centers that we need for the study. But again, if you have not yet communicated with us, we're happy to, and you would like to participate, we're happy to talk to you and consider you.
So great. So this is really also a testament to persistence. So congratulations to you and Dr. Trivedi, because it's, through the process, you get a lot of like rejections, denials, pendings, but it really is about taking that information, turning it around and making it the best study it can be. And so it's great to see that your persistence paid off.
Thank you. Thanks, Don.
It's a great study. We're really excited.
Great. Thanks, Don. Thank you, everyone.
Okay. I don't believe it. Is Melissa here for this one? Are you gonna
I
present?
don't think Melissa is on, but just to remind everybody, this is S1703. And again, looking at serum tumor marker directed disease monitoring versus usual care of scans. I don't know if there's the next slide. This has been open for a little bit, but you can see that there has been steady accrual. We really appreciate sites opening up this study. You can see the step one registrations. You have to register first, make sure that the patients are eligible, meaning their tumor markers drop, and then they get onto the randomized arm. And so both arms have been really actively accruing. You can see there was a bit of a dip during COVID, but they've made a lot of modifications to the study in order to enhance recruitment, to increase eligibility, to make it easier both for patients and sites. So slow and steady progress. This is not a CCDR study. Somebody just asked that because it was developed prior to that. It actually falls under cancer prevention and control. So there's a partial credit given to screening and then an additional credit that's given to registration, although I don't know if we use credits anymore. So maybe it's just enrollment, I'm not sure. So some of the steps that have been taken to improve accrual have been to define champions from other cooperative groups such as the Alliance and ECOG Akron. There are regular webinars that are set up with the CRAs and site PIs that have been well attended, and a lot of that information has gone back to make modifications to the protocol. This is a study where remote consent is allowed. The other things that are ongoing are to reassess the non-inferiority margin and to consider a revised statistical plan to hopefully address the overall accrual goals. And then to also have brochures available for patients that are interested in being part of it. With that, I don't think I'm going to go through all of this, but lots of work underway to try to make it easier for sites. Okay, I think we can just skip all those. Okay, so with that, we're gonna, I don't know if you want to introduce our next speaker.
Yeah, absolutely. So it's Dr. Elizabeth Henry. She's from Loyola University, and she's the medical director for the MedNet, and she's going to give an update on MedNet's partnership with Swog. Thank you for coming.
Thank you for having us. So thanks for that introduction. I'm Elizabeth Henry, and some of you may be aware, our founder, Nadine Husri, who's a radiation oncologist, had given an update to this committee a couple of years ago, probably the last time we were in person. And since then, we've had some exciting partnerships with Swog, looking at ways to utilize the MedNet to gain insights into clinical trial implementation and enrollment. So if we can go to the next slide. So just a brief introduction to those of you who are not familiar with the mednet.org. This is a virtual platform, which is a space for physicians to discuss clinical questions in oncology that may not be addressed directly in the guidelines. It takes our traditional solution for tough questions. So as many of us know, we often ask our expert networks, ask colleagues for input on challenging cases, It takes that process and essentially puts it online. You can see in the graphic to the right, essentially that's the workflow. Physicians submit a question through the portal. We have a team of editors who moderate all of the questions that are submitted to the site. And then those are sent out to, directed to experts who've agreed to participate in answering those questions. This allows oncologists across the country to access strong expert networks at top cancer centers. And at this time, you can see at the bottom our breakdown as community and academic and trainee participants, but we have over 13,000 oncologists who participate on the site. We have over 700 academic oncologists who have answered questions. This is an opportunity for our experts to highlight ongoing trials, publications, and their own expert experience. There are over 6,000 question and answers within our oncology communities, which span medical, radiation oncology, gyn-onc, pediatric hem-onc, and classical hematology. And these have been viewed over 2.5 million times. And then our growth this year is to expand into some non-cancer specialties, as you see here. So our partnership with SWOG, we've worked with the Lung Community Engagement Subcommittee to kind of work in two tandem pilot initiatives. One is to raise awareness for ongoing accruing clinical trials, and one is to gain insights from our community practitioners in terms of barriers to enrollment for certain trials. So in terms of raising awareness, we've partnered around SWOG 1827 and 1914, working with the PIs of those trials to do some outreach and awareness drives. So the workflow for this, we've invited NCORP members who are participants through SWOG. Via their NCORP PIs, we've invited them to join the platform and participate on the MedNet. We then deliver targeted information about these clinical trials through Q&A that have been directly answered by the PIs and emphasize the study's relevance in those areas. And then we gather poll questions that also give us a snapshot of real world practice and how oncologists are thinking about trial implementation. And on the site, we link out directly to clinicaltrials.gov. So the oncologists participating and reviewing and coming back and searching those questions have the ability to find the trial information directly. So this is just how it appears on the MedNet homepage. You can see in the graphic, there's a feed of questions in the middle. We've featured one here from Chad Rustoven, who had answered a question around his trial. You can see the discussion is featured. Physicians can click in for more information. The SWOG emblem is there highlighting this as a special series Q&A, and then the trial PI is identified as an expert respondent. And we're happy now to be able to share the engagement metrics from this initiative. So you'll see here a few different metrics. On the left, we were able to reach through running this Q&A over a period of about 12 to 14 weeks. We were able to reach over 2,500 unique oncologists who viewed the questions and answers from this program. Overall, we saw around 9,000 views of these 8 Q&A in total. So most physicians who use our platform tend to come back multiple times to view the Q&A and continue to read the answers and gain more information, sometimes as they're engaging in clinical care at the point of care. And then the average time spent with the SWOG Q&A was about 7 minutes in total, which is actually higher than the average we see. Most of the time, this is an interaction that's, again, a brief digital interaction for physicians to seek information in real time. So the second partnership we're working on is to help gain insights. One of the advantages of our platform is to be able to really quickly gather a sense from the community in terms of what practice patterns look like. So we've partnered with the Lung Committee around 2 trials for this. So the first SWOG 1709 or the Insignia trial, we worked with Dr. Ann Chang to answer 2 questions related to treatment decision-making in PDL greater than 1% non-small cell lung cancer. You can see from one of the polls that ran with these questions that we were able to really highlight some limitations in awareness and adoption. When polled within the first few days that this poll ran, we had nearly just over 80 respondents, all having a really set treatment pattern. And despite the option for trial enrollment there, it was not selected. We ran a second poll with this Q&A as well, which uncovered some clinical factors which may influence treatment decisions among oncologists. And we shared that information back with the committee so that they can utilize that for education and awareness around this trial. And finally, we did also partner with running a question to understand some barriers among the radiation oncology community around the enrollment in SWOG 1933. What we had found was that radiation oncologists were hesitant to enroll into this trial, and there was a theory that that might be because of some of the dosing differences in the community versus in academic centers. So we ran a poll asking about radiation dose for stage 3 non-small cell lung cancer, and you can see in the range of responses here that there was variation between community in blue and academic oncologists in orange in terms of their dosing practices in the radiation setting. This was again presented back to the lung committee, and there were discussions about possible amendments to be more inclusive of these broader dosing schemas if needed in the future. And again, just highlighting that the amount of engagement we're able to get over a short period of time is a successful way to bring this trial information out into the community. Thank you.
Any questions?
That was great. Does anybody have any questions or thoughts about how to engage with these social media platforms, either for generating ideas for studies or getting feedback on eligibility criteria or other potential barriers to enrollment? Because it's a great resource that we can use both for an implementation perspective, but as well as for a research perspective.
I have one question.
Sure.
I'm Krista Browning West from University of Hawaii Cancer Center. And is it just for oncologists, or can advanced practice providers be involved in this? Because sometimes I'm an advanced practice provider and have a lot of questions that might be really relevant and need feedback.
Right, and thank you. That's a great question we've heard before as well. Right now, the platform is limited to physicians, but there are things that we're thinking about as growth initiatives, and that's certainly a question that's come up, and we would be looking into expanding into non-physician specialists in the healthcare teams as well.
So really looking forward to working with you on
Yes,
S1934. So one of the things that we are challenged with is with recent FDA approvals, even though the patients who are approved for the new drug treatments would not have been eligible for the trials that led to those approvals, there's some concern that NCI has expressed about how practice change might creep and how that could affect the trials that we have designed. We've had to modify, with that in mind. Is this a good forum to educate people on eligibility criteria differences, and also more importantly, to be able to put a finger on the pulse of where practice might be changing irrespective of evidence and how that could affect us?
Yeah, I think that's a great question, and that would be certainly an example of, if there are questions that you guys are hearing as investigators that are coming up in committee discussions, we do have ways to look at polling responses over time as well. So that would be an opportunity where we could potentially ask a question about, a practice behavior, and then over time sort of clock what is actually happening in community practice. How is it changing? How is new evidence being integrated? So I think that actually is a terrific potential use of the MedNet. And I think one thing we're certainly interested and open to is if investigators are hearing these as questions or barriers or as studies are being reviewed, we're happy to discuss those and see if we have questions that were existing from the past where we have some information we can contribute, and then sort of bring those up into current practice and see what's going on. And then I think the question around barriers to enrollment, et cetera, and how to identify, within using the site as an educational platform to educate around eligibility criteria, et cetera. That's what we're, hoping that the PI answers are highlighting in terms of who they're really considering for these trials, so that oncologists, as they read them, if they have a patient sitting before them, they may be able to then go and kind of quickly see, okay, yeah, this type of patient should be considered. And if they're outside of the trial parameters, then what would people do? That's often how the site is being used anyway.
That's great. And so just from the chats, if people have, want to contact you directly about using the MedNet for these kind of programs to increase accrual, can they just reach out directly to you?
Definitely. So I'm Elizabeth at themednet.org. So it should be, I should have put it on here, I failed to, but I can also get that out with any slides that go out after the meeting.
Great. Thank you
Thank
so
you.
much.
All right, next up, Karen Ferris, who I believe is going to join us remotely, is going to talk about 2201 CD effectiveness of the OAA Rapid Pro model, pragmatic clinical trial with convergent mixed methods. Say that one.
Nice short title. Can you hear me okay?
Yes, thank you.
Okay, this is Emily Mackler. Karen and I are working on this project and she was unable to attend today, so I'll be presenting on our behalf. If you could go to the next slide, please. So a few updates to the group related to this. We did resubmit the grant related to this project to Health Services Quality and Effectiveness Study section of the NIH just last month. We've made several changes that we think actually have made this a much better project and will be much easier for enrollment as well. Initially, you may recall that our randomization had been practice-based in our original proposal. We have modified this to be patient-based. We also, in our first proposal, included all oral anti-cancer agents within our assessment, and we've now limited this to a more homogeneous population of tyrosine kinase inhibitors. We have excluded CML because of the amount of research that's already occurred within that disease group specifically, and also some differences in the time on therapy for treatment with CML so that we can better assess our patient-related outcomes with the study. Overall, the approach itself is much less complex. Practices will be sent the Rapid Pro, which is a patient-reported outcome tool that assesses patient symptoms and medication adherence, and they will be sent results for follow-up with those indicators of follow-up being needed based on how patients scored their symptoms highlighted for the practices. Karen and I want to really express our thanks to all of the individuals who have helped us with both submissions, for the grant support, to Dawn and Joe and Scott for their scientific input and support. So thank you. Next slide. So to review the aims, we are looking at quantifying the effectiveness of this oral anti-cancer agent Rapid Pro model on reducing treatment failure at 12 months for patients with cancer taking TKIs. We also wish to characterize the extent to which patient factors contribute to health inequities, predict or modify the effect of the model on treatment failure, adherence, quality of life, and healthcare utilization. And finally, our third aim is to identify the facilitators and barriers of fidelity and sustainability of this model. Next slide, please. So this is a schema to show the incorporation of the aims with this model. So we'll be looking at adult patients, as I indicated, who are being prescribed a tyrosine kinase inhibitor. The PROM tool, so the Rapid Pro, will be able to be filled out by patients via smartphone. And so one of the inclusion criteria is that patients will be able to use a smartphone and an app. Those who do not have one will be provided one for the study. We'll be randomizing a goal of 794 patients, approximately 400 in the usual care arm, and then another 400 in the intervention arm. With that intervention arm, we'll be incorporating the PROM tool in following and management and follow-up of the patients. And that incorporation for that arm of the study, we'll be looking at how the incorporation of that PROM at year 1 impacted treatment failure, which is a composite endpoint, medication adherence using a validated 3-item system by Wilson and colleagues, health-related quality of life with the Promise 29 survey. And then also we will look at healthcare utilization, documenting ED and hospitalizations between arms of the study. That will be done via chart review. As you can see here, AIM 2 will not collect any additional information, but we'll look at how these particular components of the participants and practices may impact the outcomes that we'll be assessing. And finally, for AIM 3, we will be conducting interviews and looking at both quantitative and qualitative information to assess the fidelity and sustainability of the model. If you could go through the next couple slides, it's more information on AIM 1, 2, and 3, and we can go beyond that. So what do the practices receive for participation? The option to use the Rapid Pro within those patients that are randomized, which is a proactive assessment of symptoms and adherence for participants in the intervention group. As a reminder to this group, Karen and I have studied and worked with this model within the state of Michigan with multiple practices to assess symptoms for patients and highlight those who were in need of additional clinical care. We'll work with the practices to see how that additional time spent in follow-up can be reimbursed. We in the state have worked a lot with practices on the ability to reimburse or bill for care management codes. We can support the practices in opportunities that are specific to their state as far as billing allowances. Site payments that can be received would be $180 per patient at baseline. Additional reimbursement for the personnel interviews and how we'll conduct those over the next couple of years. Next slide, please. We're really excited about this grant and hope that it will be supportive. We really believe that proactive monitoring will increase patients' time on therapy of their medications and ultimately improve and enhance their clinical outcomes. We believe with this proactive monitoring that the side effects patients experience will be responded to more quickly. Patients will be able to stay on their therapies. And of course, those outcomes will be positive. We know one of the barriers of implementation and additional follow-up for this patient population is related to funding. And so we hope to support the practices in the opportunities that exist to bill for follow-up codes. We hope to study and then make adaptations to reduce health disparities for this patient population, and then begin looking at facilitators and barriers that could sustain this model in the future. Next slide, please. We'd love to hear from you. If you have any questions, interest, concerns, aspects you'd like to discuss as we move forward, please feel free to send either of us an email and we'd be happy to talk more.
So thank you so much. I think, you know, our fingers and toes are crossed for the next grant, and but we think this is a really key area, and TKIs in this patient population are really understudied. And so, you know, we're determined to get this study done. That being said, I think we're going to move on. We were going to get a very, very brief update on the patient-centered video education intervention to improve rural cancer care delivery from Azumi Okado. And this is a study with Randall Holcomb. This is a study that was funded by the Hope Foundation as a seed grant, if I'm not mistaken. And so this is just to give sort of an update of where we're at with that.
Thank you, Dr. Hirschman and Dr. Ramsey, for the opportunity to present updates on this study. I'm presenting on behalf of Dr. Randall Holcomb, who is the PI on this study. We have specific aims for the study. The first aim is to assess rural cancer patients' perceptions of care coordination using a validated instrument. And the second aim is to develop and pilot test a TED Talk model patient video education intervention that's specifically designed for rural patients with early stage cancer. And the study design for these aims are The first aim is a cross-sectional survey, and we are looking to recruit 60 adult patients with early stage cancer who are receiving adjuvant therapy. And the aim 2 is a feasibility study. It's a single-arm pre-post intervention design. And the intervention is a tablet-based patient video education, and that includes cancer basics, care coordination, and self-advocacy. The current updates, aim 1, we are happy to report we are now up to 56 patients. So we've completed over 90% of target accrual as of today. And aim 2, we enrolled 2 participants to date. We recently completed an on-site staff training on Kauai. So we anticipate the enrollment will increase in April. There have been a number of challenges, and we've made some plans to address these challenges. And these include modifying study procedures, so the studies are conducted remotely. And we've also added a rural clinic on Maui as a study site. And Dr. Holcomb and I are currently trying to open the study in rural areas of Vermont. Dr. Holcomb is in Vermont now, and he's working to open a parallel study there. And this will allow us to look at a larger sample size in a complementary study population. Thank you. We look forward to your questions and comments. And I think Dr. Holcomb is available on Zoom for questions as well. Thank you.
Any questions? Other than, can I fly out there and do a site visit?
Great. Well, we look forward to the data and for figuring out how to then take that and move it forward to a SWOG-led trial.
All right. We are now moving on to S1904, and take it away.
So I'm Kathy Cruz. So S1904 is mainly housed in the prevention committee, but it has many CCD components that's relevant to this audience. And the main issue that this trial addresses is underutilization of chemoprevention, breast cancer chemoprevention in high-risk women. So we have this multi-level intervention, real risk and BNAV, which are web-based decision support tools for patients and their healthcare providers. And so since it's multi-level, it's a cluster randomized control design. So we have 26 sites that are randomized 1-to-1 to the active intervention versus standard educational materials. We're enrolling 200 healthcare providers and then 415 high-risk women. And our primary endpoint is a patient-reported outcome, which is chemoprevention informed choice after their 6-month follow-up. So this trial has been active for the past 1.5 years. So I'm mainly going to focus on the successes and also some of the challenges. So one success is we've already got all 26 sites, recruitment centers randomized as of December of last year. And at least 24 of those sites have enrolled healthcare providers, so we're already about 3/4 of the way of enrolling healthcare providers. There's an implementation aim as well, because this is an R01 funded study. So we're about 3/4 of the way of doing at least the pre-implementation interviews of the healthcare providers. And we're about 1/3 of the way through in terms of patient enrollment. So at least 18 of the 26 sites have enrolled at least 1 patient. Next slide. This is the breakdown in terms of provider level recruitment at least 24 of the 26 sites. And it's fairly diverse professionally provider population. So nearly half are medical oncologists, about 30% are surgeons. We also have some primary care doctors. 3/4 are MDs, and then about 25% are allied health professionals like NPs, PAs, and RNs. In terms of patient accrual, like I said, we're about 1/3 of the way there. And if we can get to our target of about 15 to 16 patients per month, we should be able to complete enrollment within the next 1.5 years. We're already into year 4 of the R01, so hopefully we can finish that enrollment by the time the grant ends, and probably need a no-cost extension to finish a 1-year follow-up. So one of the things that we're very conscious of not increasing health disparities with this technology-driven intervention. So at least 4 of the 26 sites are MU NCORE sites, and Nearly half of the women that are enrolled in this trial are underrepresented minorities. So about a quarter are Hispanic, another 8% are African American, and 7% are Asian. So that's the challenge, is like advancing the slide. So the big challenge with cluster randomized trials, so to really enhance the power of the study, we want to have approximately equal accrual of patients at each of the sites. So 415 patients across 26 sites should be an average of 16 patients per site. So you can see that there is differences in terms of patient accrual. Some have already enrolled over 16 patients, so we're capping enrollment to 32 at any site. But, you know, we really want to try to get the sites as engaged as possible to try to have that balanced accrual. And so we have these monthly calls with each of the sites, and you know, a few of the sites haven't enrolled any patients yet. So we're really trying to address those barriers to accrual at those individual sites. There is also some imbalance in terms of, you know, because we're relating to Dyads. So we are also enrolling patient provider Dyads, because it's a provider and patient intervention that we're using. And so one provider can enroll multiple patients, but we found that there are some providers that are really gung-ho about enrolling their patients, and that in some of the sites, oftentimes they're initially seen by the oncologist or the surgeon, but then it's the NP that will then follow them in terms of their long-term follow-up care. So I think it's okay if there's imbalance in terms of patient-provider recruitment. I think what's more important is getting equal accrual at the site level, because that's the unit of randomization. And then the last challenge that we have, so this is a fairly low-touch web-based intervention. And what we found is that, so about 3/4 of the patients have at least viewed and logged on to the site, but a little less than half have actually completed all the modules within real risk. So I think that's the other challenge too, particularly in a high-risk population that doesn't have cancer, to try to make it such that they remain engaged and actually complete the intervention. So that's the other challenge that we're trying to address. And then if anyone has any questions, we'll go into this in more detail in the prevention committee, but I thought I'd just share some of the insights that we've had thus far.
Thanks, Kathy. Any questions?
Hi, Rick Bangs, the chair of the Patient Advocate Committee. So I think you kind of really glossed over something that I'd like to hear a little bit more about. I saw 26% Hispanic. Okay, can you talk a little bit about how you've got that high level?
I forgot to mention that our real risk tool is available in English and Spanish.
Okay, that helps.
Yes, and that and some of the highest accruing sites that we have thus far are those MU and core sites that have high Hispanic patient populations.
Okay, thanks.
Thank you.
Yes, so I think there are a lot of lessons for us to learn. We talk about these multi-level interventions. They're super complicated. It's really takes that kind of dedication and commitment on behalf of the study team to sort of stay on top of all of that. And so for anybody thinking about doing these complex studies, you know, definitely reach out to other investigators that have done it for lessons learned, because this is really a beautiful example of, you know, how you can achieve all of these goals simultaneously.
All right, so we're going to finish strong with Lynn Henry's S2010 Aspire study.
Yeah, so thank you so much. This is a new study that's R01 funded that Don and I are doing in conjunction with Joe and Ria and many other people. So I thank everybody. Also, we're not calling it Aspire because that's too positive. So I'm thinking maybe Aspen.
That's right.
So I'm going to go through this part really quickly because we don't have very much time. Really, this is just focused on endocrine therapy persistence, trying to increase persistence with this important medicine in young women with breast cancer. You can click through a lot. You can keep going. And so the intervention that we're using is called active symptom monitoring. And this is something that has been tested in metastatic cancer by Ethan Bosch and others. And it's really routine assessment of patient-reported symptoms in between clinic visits, and as opposed to doing it just when the patient comes into clinic. Next slide. And it's been shown to increase survival in metastatic cancer, has also been used for monitoring of things like chemotherapy toxicity, but we're trying to apply it to a different population. So our population is exclusively premenopausal. They have fewer symptoms attributable to the cancer and more symptoms attributable to the treatment. And they're also not seen in clinic very often, only every 3 months or so, as opposed to in the metastatic setting where you're seeing patients a lot more frequently. So our hypothesis is that active symptom monitoring will increase persistence with oral endocrine therapy, mostly by increasing patient-provider communication. Just asking questions is obviously not going to improve their tolerance, but we're also hoping that by getting people talking to each other, we'll be able to intervene sooner and reduce toxicity. So even though this trial primarily sits in the Symptom Management Quality of Life Committee, it's not actually designed to be a symptom management trial. So the primary objective is to investigate the impact of active symptom monitoring on oral endocrine therapy persistence in this premenopausal population for 18 months. Secondarily, we want to look at the impact on symptoms. We want to look at patient-reported as well as some objectively measured biomedical metabolite concentration adherence. And we also want to build a risk model of non-persistence with endocrine therapy. So eligibility, women have to have been premenopausal at the time of breast cancer diagnosis. They then have to be postmenopausal when they are going on the trial. So they either have to be on an GnRH agonist, they have to have chemotherapy-induced ovarian failure, or they have to have undergone bilateral salpingo-oophorectomy after the diagnosis of breast cancer. And we're allowing people to enroll up to, I think it's 2 weeks before, it's changed a little, or 2 weeks after endocrine therapy initiation to allow a little bit of flexibility. Patients can have had prior endocrine therapy. There's a lot of details there. They can have a lot of concurrent medications, and we are having this available in English and Spanish to try to keep it as diverse a population as possible. They do have to have either internet access or telephone access for IVRS completion of questionnaires. So patients are randomized, either everyone gets patient education, half of the group is randomized to active symptom monitoring, which is simply filling out 6 questions every week for the first 6 months, and then every 4 weeks. And it's about fairly common symptoms that we hope are relatively easy to intervene on, like pain and depression and anxiety and things like that. Next slide. Those are the 6 symptoms that are listed there. They'll complete it using a tool that's developed by UNC Procore, which is the same thing that group that Ethan Bosch has used. If a symptom isn't very significant, they'll just get their next questionnaire the next week. However, if it meets a specific trigger, then the site will be notified that the patient has met this an increase in a symptom, and then it'll be up to them to decide what to do. Do they want to reach out to the patient, find out more about it? Do they want to do an intervention? We will capture the contact and what is done by the sites, but we are not mandating any specific interventions be done. You can do the next one. And so we're looking at a number of patient-reported outcomes. Importantly, we are going to include a fairly comprehensive social determinants of health questionnaire at baseline in this study. We're also just looking at a lot of different symptoms, as well as brief medication questionnaire, self-efficacy, and then the patient-reported adherence measure. We're looking at estradiol levels, as well as drug concentrations and metabolites at 4 different time points. And the primary endpoint is discontinuation of initially prescribed oral endocrine therapy, either the aromatase inhibitor or tamoxifen. It's up to the site which drug and what dose for at least 60 days. Or if a patient switches from one to another for any reason, that will be considered in the endpoint as well. So we are not we're trying to make this as pragmatic as possible. And so, as I mentioned, it's funded by an R01, which is really covering the cost of the intervention, as well as IT support and all the interactions between SWOG and UNC Procore. It's also covering the cost of the correlative studies. The total of 540 patients randomized 1-to-1. And as I said, primarily symptom management committee, also secondarily through here. And we will be trying to enroll primarily in NCORE sites, including Latin America, but it's obviously open to all the NCTN sites as well. So thank you very much.
Any questions?
Hi, Barbara Sagara, patient advocate. Great, because I know this has always been the endocrine adherence is an issue. And I think it's about education. So two questions. The education piece at the beginning, is it reinforced? Because I think most of the patients don't realize the importance, the life-saving that endocrine therapy can be, right? I have took it 6 years and now I'm in my 5 years again. So, and you learn how to manage your symptoms, and I know they vary. And my second question is if part of the thing is catching early these symptoms to find some kind of relief before you get your next appointment. So you said you're not going to require the what they're going to do. At least you're just going to see if they were notified. So at the end, do we know then if this is really going to help? Because I think what really will help is having an intervention for them not to leave the medication. So that part I was thinking about.
Yeah, so in terms of the patient education that we're doing at the beginning, it's not really tailored to patients in terms of, this is your risk of cancer recurring. We can't do it at that level. What we're doing is we're providing web links to both cancer.net, which is ASCO's patient education information about breast cancer and about treatment and side effects and side effect management. We're also providing information to American Cancer, the cardiology websites about healthy living and lifestyle and exercise and things like that. And those are available in English and Spanish. So that's the patient education that we're doing. We're not dictating what the physicians do in terms of their practice, but what we are doing is we are providing information in the protocol about suggested interventions for these 6 different symptoms, in the hopes that we may also help spread some of the information to everybody about different ways to manage depression or hot flashes or pain or things like that many providers know, but some may not. And so we are providing information, but we're not saying you have to go through a specific algorithm in terms of how to treat an individual patient.
So I have a question along with that is, so you have 6 things where these patients can act on as far as symptoms, and these are all outpatients. As far as getting the data and getting reliable data, it sounds like a big, difficult mission. How are you doing that? And especially in Latin America, you'd be are you just patient report, or how are you going to get reliable? Otherwise it'll be, I'm not sure how useful it'll be.
Yeah, that's a good point. So I went through things very quickly. So I neglected to mention the primary endpoint is all based on those longer questionnaires that we will be collecting at the time of clinic visits on paper. So when patients come into the clinic every 3 months, we will be having them complete the questionnaires about their symptoms, and everyone will be collecting those. The intervention itself is trying to collect these symptoms in between times. And so we will be able to look to see how often do people fill it out. We know from the experience from some of the Alliance Foundation trials and things that have used it before is that people are very gung-ho about using it initially, and then it sort of tails off. So we have recommendations in the protocol about when the site should reach out to patients if patients are not completing the questionnaires, not to badger them about completing it, but more to make sure that there aren't technical difficulties for why they're not being completed. And so we're going to be able to capture all the information about who completed, who didn't, what did they report, look at trajectory over time of these symptoms in patients. And then we will be able to look to, part of the question is, how receptive will people be to answering these questions, and we'll be able to find that out. But we're hoping that by raising the patient awareness of her symptoms and the fact that these should be reported, and by increasing the communication, that hopefully that will lead to an improvement in persistence. And if nothing else, we may be able to learn a lot that could then lead to future implementation trials like we were talking about earlier today.
So let me just, so like insomnia. So patient says they have insomnia. Are you trying to collect whether they're taking a medication or they're behavioral? Does that matter?
We
Or
are
is it-
collecting that as well.
And that's patient report saying what they did.
That when the patients are seen in clinic, they will be asked what medications they're taking, what other things they have used.
So we're out of time. Sorry. Feel free to follow up with the investigators. Thank you all so much for coming. We hope to see you in Chicago at our next meeting. Hey, Barbara. Good to see you. Oh, absolutely. Yeah, you're coming? Excellent. I'm so glad. All right. Well, it'll.
Good to see you. Yes, yes, yes. And let us know how, you know, how. So, I was gonna say, like, what you want to do more of, what you want to do less of, what, you know, if there's anything we need to be doing differently, just let us know. Right. Right. The only problem here is that everybody says the same thing in the meet, in all of them, so that if you go to multiple meetings, you hear the same thing. So, yeah, maybe just to sort of like focus those things down, but we can definitely do that going forward.
Yeah, well, you're going to get busy with the clinical trials planning meeting too. So, and that'll get going, you know, and then I'll start coming back here. No, it'll. No. Oh, that's good.
Fantastic.